Dr. Mark Piper, who needs no introduction. Dr. Piper is an icon in the TMJ world, in the world of craniofacial pain, and he has a pedigree that is beyond belief. His CV is amazing. He was admitted as a Harvard National Scholar to Harvard College and majored in chemistry. He received his Bachelor of Arts cum laude in 1974. He continued his studies at Harvard Graduate National Scholar, and in 1978 he earned his DMD magna cum laude from Harvard School of Dental Medicine. He then enrolled at Vanderbilt Medical School and completed his MD degree in 1980. While at Vanderbilt University Medical Center, he was awarded certificates for completing a 1-year internship in oral and maxillofacial surgery, a 2-year basic residency in general surgery, and a 1-year chief residency in oral and maxillofacial surgery. And to round out his education there in time, he was an emergency room physician in Tennessee before moving to Florida to establish his private practice as an oral and maxillofacial surgeon. In 1984, he was one of 12 founding fathers of the American Society of TMJ Surgeons. His presentation today is sympathetic nerve dysfunction in the maxillofacial region. Please help me in welcoming Dr. Mark Piper.
Thank you very much, Cliff, for that very nice introduction. And to give you a little bit more background, in 1983, I moved to St. Petersburg to join Peter Dawson because Pete told me he had a few TMJ patients who needed surgery. And so my start in St. Pete was actually pretty fast. I saw a lot of abnormal bite patients, a lot of TMJ patients, and a lot of facial pain patients, but my real passion turned out to be treatment of the temporomandibular joint itself. So I do primarily joint reconstructive surgery, specifically joint preservation surgery, meaning basically a technique to try to preserve everything that's already there structurally through different reconstructive techniques. We're not going to talk about that today. I have had people ask me, after 35 years of doing microscopic surgery, doesn't it get a little bit boring? And my answer is no. Quite frankly, the more of these you do, the more nuances there are from patient to patient, and that's kind of where today's talk came from. It came from seeing a subset of TMJ patients who had a little more esoteric pain. And it was somewhat challenging initially to try to figure out what this was, and I'll share some of the history of that with you. But that actually is the background for developing an interest in trying to treat the sympathetic part of the nervous system, especially in doing the TMJ reconstruction patients. So I have several goals today, messages that I want to leave to you. First and foremost, I want to teach you about this nerve block. This is the greater auricular nerve, which is a cutaneous branch of the cervical plexus. I'm going to teach you the background anatomy of this nerve, how it originates from the cervical spine, and how you get sympathetic input into this particular branch. And Nick is going to follow me. He has also integrated a lot of these concepts that I'll teach you into his general dental practice, and he's going to expand it to the dental part of treatment. The second goal that I have for you is to integrate the sympathetic nervous system better into everyday dentistry. I want to start a process of unification, if I can, in the world of pain and in the world of sleep. And then another goal is to expand the envelope, hopefully, of things that you can do for the betterment of our patients. And most importantly to me, by the end of the day, I'd like to leave as your friend, okay? And that's not always easy for me to do, but I'll do my best. So, I'm going to throw this out right up front. What is TMD? And you could probably have a week-long meeting of experts arguing exactly what it is. And I know that many times when I'm speaking to groups, there is a different perception of where the presenter is coming from. So I want to tell you where I am. I reference back to nosology and classification of diseases, and you can see different options here, starting with what's called a syndrome. So a syndrome is something that can't be measured and it can't be imaged. And so almost everything in the body starts out as a syndrome, but as we mature in our diagnostic capability, you can see that we can change the name to disorder, disease, injury, or lesions. And for the most part, what I treat in my practice is the fourth category, that's injury to the temporomandibular joint, because that's what sparks most of the reconstructions that we end up doing. I also want to point out to you this concept of phenotyping versus endotyping. And the best example of this is asthma. Everybody's got a pretty good idea about the phenotype of asthma and how these patients would present when they go in to see their physician. They would have wheezing, perhaps a certain degree of hypoxia, and so on and so forth. But asthma actually has many different etiologies. And so when you get into subsetting the direct cause of asthma in that patient, that's called endotyping. And my plea to you is to think more in terms of endotyping diseases, endotyping assessments, and endotyping diagnosis. And this is what I'll try to do for you here today. So there are 6 orders of how a problem in the body progresses ultimately to an endotype and phenotype. And it has to be something that we can begin to measure before we can measure it as an injury, before we can measure it as a lesion, or before we can measure it as a disease. Syndromes, again, are not measurable. And so, question about TMJ diagnosis, you can see, again, a rather lengthy list of things that we could be arguing about relative to TMJ. This lecture is going to focus on pain and the pain part of TMJ. And my goal for you is to show you a different pathway of pain in these patients that relates more to the sympathetic part of the nervous system. And I'm not standing here today trying to say that there's no other input. I'm simply here to open your eyes to what the sympathetic nervous system does, particularly in patients who have injury to their temporomandibular joints. So this presentation is going to focus on endotyping a condition called complex regional pain syndrome type 1. This used to be known as RSD, reflex sympathetic dystrophy, and this is a pain layer that is experienced in many patients with orofacial pain. The patient base in my practice basically is 3 things. They come in with TMJ problems, they come in with bite problems, and they come in with pain. And everybody's a little bit variable as to their presentation. Many patients have had failed treatment, and especially in the population of CRPS patients, failed treatment is pretty rampant. And these patients really aren't separated. Everyone who walks in has some combination of these 3 things. And so my goal when they come in is to endotype these 3 different categories, and endotyping starts with the joint foundation. And as some of you may be aware, I have a classification system looking at soft tissue, which is the inside circle, and bony lesions on the outside circle, to begin to subset patients relative to the anatomy in their temporomandibular joints. And part of that subsetting is understanding disc displacement, both degree and direction. And to give you a very quick overview, again, not part of this lecture really, the Piper classification kind of has 2 parts. One part is the simple end of the spectrum, and in the simple end of the spectrum, the displacement of the disc is at the lateral pole. These are partial disc tears. And so stages 2 and 3 are relatively simple, and with lateral slippage, the disc will tend to slip off of the lateral pole upon closure, and it may or may not lock upon openings. This is the simple category. of internal derangement patients. And then there's a more complicated category, which would be stages 4 and 5, where there's a more complete herniation of the disc off of the surface of the condyle. And these more complete herniations are typically more problematic. So the point is endotyping, diagnosing the foundation. And in my practice, in assessment, all foundations are diagnosed with imaging. Okay, the next part of endotyping is the occlusion. And because I treat a lot of bite problems that are associated with TMJ disorders, I realized that Angle's classification is useful, but it could be better if we related Angle to the condition and prognosis for the joint foundation. And that again gets back to an assessment of the joint itself to determine whether it's generally normal or abnormal, and if it's abnormal, is it adapted or non-adapted? So for example, on one side, you could have a class 1 bite with a normal joint foundation. On the other side, you could have a non-adapted joint, Angle classification 2, and that would be a non-adapted foundation that would have a higher risk for change over time. And many times the patients that I'm going to talk about with complex regional pain syndrome fall into this non-adapted category of joint foundation, either one side or the other. So again, that's endotyping the bite. And then the third part is endotyping pain. I've used this model for a number of years where I endotype 3 pies of pain, 3 pieces per pie. And what I'm going to focus on today is pain pie number 3, which is really pain secondary to other pain problems, or secondary to stress, or secondary to some underlying physical damage. And these 3 layers tend to perpetuate, and they tend to persist. And of those 3, the focal point will be this piece right here, the CRPS type 1. And right up front, what this is a trauma or surgically induced pain pattern where the pain is disproportionate to what the patient went through. The pain can be incapacitating, it spreads along the spine, and the theme in the body is that it is poorly recognized, and it's poorly recognized in the face as well. So a CRPS type 1 patient may present with this phenotype. That may be a little hard to read for you, but let me tell you what happened. This was a lady who came in, and she had a diastema restored. Tooth number 7 was restored to close a diastema, and she developed this whole list of things. The tooth got sensitivity, occlusal adjustments would only temporarily make it better. Eventually, the tooth was treated with a root canal, and the pain spread to the entire upper right quadrant of the mouth. It then spread to the right temporomandibular joint, it spread to the chin, it spread to the left temporomandibular joint. Every occlusal adjustment, the patient got worse. She began having mandibular dystonia with protrusion of the mandible, making her premature in the incisors. And she began to complain of gingival pain, stiff muscles, facial muscles. Muscles of mastication were stiff. She had difficulty initiating jaw movement. She then developed visual scotomata, increased axillary sweating, cheek swelling, ear congestion, positional vertigo, dysphagia, and cervical pain. Okay, so that's a simple procedure, and you can see her pain ended up out of proportion to the inciting event. Okay, so what would explain all of these different types of pain? Well, if we had 20 different problems, you could have 20 different diagnoses, right? For example, the TMJ pain. Maybe she's got an internal derangement. The tooth pain. Well, maybe it was pulp that went bad. Occlusal adjustments. Maybe they weren't done right. And after a while, you say, well, it just doesn't quite make sense that we now have 20 events that have occurred because of this diastema, and how in the world can this happen? Well, the answer is through focusing on the sympathetic nervous system. Okay, I'm not sure why I jumped ahead. So the focus is on the sympathetic nervous system because that's really where the answer is. So, sympathetics are regulatory, and I want to give you a brief overview of the regulation of the autonomic nervous system. The autonomic nervous system controls vital signs and temperature. It upregulates and downregulates the immune system. It regulates our glands, and the autonomic system is divided into parasympathetic and sympathetic. So it's either rest and digest, or it's fight or flight, okay? And here is a schematic showing the two parts of the nervous system. On the left-hand part of the screen is the parasympathetics, which basically are craniosacral output to the parasympathetic nervous system. On the right side is the sympathetic nervous system, which is thoracolumbar. So the output out of the spine and out of the brain is different between the two parts of the nervous system. In the parasympathetics, it's from the brain and it's from the sacrum. And in the sympathetics, it's from the thorax and the lumbar region. And if you kind of look at what happens on the left-hand side, let's say we had two people who were in a fight. On the left-hand side, if you're more parasympathetic, dominant during the fight, your pupils are going to be constricted, you're going to salivate more, you're going to have a vasovagal response where your heart rate decreases and your blood pressure drops, and blood flow is going to go to the GI tract and make you nauseated. The other thing that it will do during the fight, your bladder is going to contract and you may wet yourself, okay? Now on the sympathetic side, it's very different. On the sympathetic side, there's going to be a mydriasis of the pupil. You're going to inhibit salivation, you're going to increase heart rate, blood pressure, dilate your bronchioles so that you can breathe better, divert blood flow away from the GI tract, but you will release more glucose to get you ready for the fight, and towards the end of the fight you may ejaculate, okay? So the two parts of the nervous system, and they do two different things. Okay, now the sympathetics actually begin their regulation at the level of the hypothalamus. And so the hypothalamus is the integrator for autonomic functions. And if you look at the MRI, the hypothalamus is right here, and here's pituitary right below it. Midbrain, pons medulla, cerebellum, okay? So the anatomy is all real close right in this area. But let's look real briefly again at this anatomy. The craniosacral anatomy, the outflow of parasympathetics typically will go through a peripheral ganglion. And then from the peripheral ganglion, there will be synapsing with other neurons that will go to the periphery and target, which oftentimes is regulation of salivary flow and so on and so forth. On the sympathetic side, there's special anatomy, and I want you to hear this very carefully. We have sympathetic nerves in the cervical spine, and we have sympathetic nerves in the face, but they actually originate in the thoracic portion of the spinal cord, okay? And so when you look at this diagram, here is your spinal cord, this is T1, and down here is L2. So coming out of the spinal segments, T1 through L2, we have what are called white rami of the sympathetic nervous system. Those are actually myelinated sympathetic nerves that then go to this trunk of ganglia that runs parallel to the spine. And that's the sympathetic chain. We have a right side and a left side. What's interesting is that they actually join down here in the coccyx. And when you look at the anatomy into the cervical spine, we have three ganglia. And so this input of sympathetic nerves will come out of the spine. It will travel up and down the sympathetic trunk. To get to the cervical spine, it has to go up to the three ganglia, and the topmost ganglia, which is the superior cervical ganglion, controls most of the sympathetic output to the head and neck. So, thoracic injury could actually change sympathetic output to the face. Okay, and it's all in the anatomy. So getting into this in a little more detail, here's a cross-section of the spinal cord. And coming out of the anterior horn, you're actually going to have communicating fibers from T1 through L2 that are going to bridge the spinal cord out to the sympathetic trunk. Okay, and you can see how the spinal cord would sit inside a vertebral body. And coming out of the spinal cord, you've got your dorsal root and your ventral root. This is your dorsal root ganglion. They form a spinal nerve. Okay, but the spinal nerve may not have sympathetic input if it's in the cervical spine. It has to get it by having the sympathetic chain send out what are called gray rami, which are non-myelinated sympathetic nerves that then join the spinal nerve. And sympathetic nerves are hitchhikers in the body. They like to follow something else that's stronger. And so they'll hitchhike with sensory nerves. They'll hitchhike with the sheath of the neurovascular bundle. They'll hitchhike with blood vessels. And so this is the basic anatomy that we have in the body. And in the cervical region, you basically have your inferior, middle, and superior cervical ganglion. These are also going to regulate most of your heart rate and blood pressure. So it's in the sympathetics. It is the superior cervical ganglion up here that really is the beacon from which most third-order neurons will originate and spread out into the periphery. So, postganglionic sympathetic gray rami join the cervical spinal nerves and follow these sensory motor nerves into the periphery. That's take-home message, okay? And I don't know why this is jumping. And so they're going to follow into the periphery, and they're going to form nerve bundles. And when it comes to headache pain, we have ventral fibers and we have dorsal fibers. The dorsal fibers are on the back of the head. There are two nerves. Greater occipital nerve here, and then the least occipital nerve down here. So those are the nerves that are going to be formed from the part of the spinal nerve that goes posteriorly. And then those that go anteriorly are going to form the cervical plexus. And they're going to join different levels together to give us that sensory motor nerve out to the perimeter. And if you look down here, you'll see where the C2 ventral ramus will join C3 ventral ramus right here. And those are going to give off several nerves. Lesser occipital, greater auricular, what we call transverse cervical, and then down here, supraclavicular. And the point of this lecture is we can reach those nerves with nerve blocks. And when you do the nerve block, you have a diagnostic insight into the origination of pain that the patient may be complaining about. So more on that later in terms of nerve blocks. So the sympathetic nerves to the face are going to start first order neuron at the level of the hypothalamus, and that's going to travel down the spine to the lateral horn of the spinal cord. And then there's going to be a synapse with the second order neuron that's going to come out of the spine, and it's going to go to the sympathetic chain. In the sympathetic chain, that can then go up or down. To get to the cervical region, it's got to go up. And when it goes up, it can reach another area where it will synapse and send out a third order neuron that's going to go to the periphery. So first order neuron is all central nervous system. Second order neuron is from the spine into the sympathetic trunk. And then third order neurons are from the sympathetic trunk into the periphery. And those nerves are going to tend to follow blood vessels, and they're going to tend to follow nerves. So that's the basic anatomy. All throughout the distribution of the carotid system, you will have sympathetic nerves following the arteries, okay? So how do we block this? Well, you can't really block first order neuron or you'd be injecting the brain or the spinal cord, and that's not tolerated well by patients. Second order neuron could be blocked at the sympathetic chain. And this is what we do a lot of times when we do what's called a stellate ganglion block. We're blocking the sympathetic chain, okay? We're blocking those sympathetic nerves as they're going superiorly and inferiorly, okay? You could also block at the third order neuron, and to do that, you have to pick a nerve or you have to pick a blood vessel that you're going to infiltrate around to decrease the sympathetic tone in the sympathetic nerves that are following that structure. Okay, and more practically speaking, that's where we do the blocks, okay? Now, when you think about teeth, there are three different ways that sympathetic nerves could get to the teeth. One is through the pathway I just described and the anatomy I just described, where it's actually coming from the brain to the lateral horn, back out to the sympathetic chain, and then from there, following one of the spinal nerves. And specifically, what's very interesting is that the greater auricular nerve, which is a neck nerve, actually crosses the angle of the mandible, and it will control sensation to the angle of the mandible and to the earlobe. And it also brings sympathetic fibers to the posterior mandibular teeth. And the reason many people are sensitive, even after they've had an inferior alveolar nerve block, is because of the sympathetic input. And if you have these patients, you can't get numb. If you did a greater auricular nerve block, they would get numb, the pain would go away, and interestingly, trismus goes away. Okay? More on that later. Nick will have a lot about that in his lecture as well. Second pathway to teeth is through blood vessels, through distribution of the carotid artery, smaller branches, until eventually you get to the arterioles that are going into the pulp. And then the third pathway is through the sheath of the trigeminal nerve. Okay, so 3 different pathways of getting there. The dental pulp is highly innervated. It does have A delta, A beta, and C fibers in it. And the discharge from the sympathetic nervous system typically comes from more non-myelinated fibers. So those would tend to be more of the C fibers, okay? So what I want you to think about with regards to the sympathetics is they're regulatory. They're regulating blood flow. And the reason you have a parasympathetic side and a sympathetic side is to regulate body function between those 2 parts of the autonomic nervous system. Sympathetic nerves are called upon to redirect blood flow. So if we are getting into a fight or flight type of response, we want to get more blood flow to our muscles and to our skin and less to our gut. And when sympathetic nerves are discharging more, they are creating vasoconstriction. Okay, so there will be vasoconstriction where the sympathetic output is increased. And part of the problem with sympathetic constriction is that we can get leakage of vessels with buildup of edema. There is an inflammatory response that starts as well with this process. So if you trigger sympathetic nerves, you're going to get a localized inflammatory response, which is going to give you nociceptive pain in that region. Now, compartment syndrome was actually first described in 1881 by Richard von Volkmann, and basically von Volkmann talked about, more in the leg, having a compartment syndrome, which would be a femur fracture. There's tight fascia in the leg, and from bleeding from the femur fracture, there's buildup of pressure that gets so high that it chokes off blood flow. That's a classic compartment syndrome. And so that type of patient has to have a fasciotomy to decrease that pressure to improve the blood flow. The dental pulp is the classic compartment syndrome. You have this hard outer shell, you have blood flow in the middle, and you can get leakage of vessels creating edema. And if the edema is persistent, it will create hypoxia from decreased blood flow. And if the hypoxia is not treated, you get necrosis. Okay, that's what compartment syndromes are all about. And if we don't recognize the compartment syndrome early enough, it results in tissue damage. Okay, and that applies anywhere in the body, whether it's a tooth or the femur or the TMJ or whatever. Not recognizing early pathology, we end up treating more neuropathic pain instead of the originating pain that may be sympathetic induced. Okay, so prolonged vasoconstriction can result in pulpal necrosis, just like we can get necrosis in the condylar head or anywhere else in the body. Allodynia is a pain response to things that normally don't hurt. And the definition of CRPS type 1 is that you have no other explanation for the pain. So if you have a patient with dental pain, particularly to cold exposure, that is an allodynia. Okay, if they don't have periodontal problems, they don't have prematurity, knocking the tooth, and so on and so forth, to explain the pulpitis, they simply have tooth pain. You have to think about the possibility of a sympathetic induced pulpitis as part of the differential diagnosis, okay? And again, you want to try to prevent the cascade of tissue breakdown. So again, blocking these nerves, you can block for a tooth pain, you can block at any of these areas. You could block at the second order neuron at the level of the stellate ganglion. You could also block more peripherally. It's almost impossible to infiltrate local anesthetic in the body and not get some sympathetic block. There are areas that are richer in sympathetic nerves than others, and the greater auricular nerve is one of these examples. So, complex regional pain syndrome, reflex sympathetic dystrophy looks like this. They are going to have a history of trauma or surgery to the affected area. This is a patient of mine from Miami. She had her dental work done by a guy who carried his instruments in a suitcase. And she didn't like to leave the house, so we came to her house and did restorative dentistry. After restorative dentistry, she had severe complicated facial pain. So that's the trauma, it was the dental work. Sympathetic nerves activated from the trauma create vasoconstriction, and for reasons we don't know, the sympathetic input doesn't decrease again. There's no feedback loop to turn it off. Pain is disproportionate to what was done. The duration of pain exceeds the normal period of healing in the patient, and they get a non-dermatomal distribution of pain. We call that a thermatome. And the thing that's unique about sympathetic pain patterns is, just like in the example patient I gave earlier, they have pain that can only be explained two ways. One, they have multiple sensory nerve dermatomes to explain the distribution, or number two, they have a broader region where the sympathetics are controlling blood flow, and that's what we call a thermatome. Okay, so they have a non-dermatomal distribution of pain, and they have evidence at some time of one or more of the following conditions. These are actually the 4 diagnostic categories that I'm going to get multiple times in the lecture. So, they have dysfunction of the nervous system creating altered skin blood flow, sweating, and a pilomotor response, goosebumps. Okay? They have edema in the affected area. They have a movement disorder. This is a hallmark of CRPS type 1, is movement disorder. This is a big part of the differential diagnosis of mandibular trismus. And then they get changes in tissue. They can have dystrophy or atrophy. And Fanny actually had all of those things, and they can have periods of remission and relapse with the condition. Weather changes the pain, so does emotional stress. And so the downregulation from emotional stress actually allows the neuropathic pain to progress or to express itself. Every one of you knows somebody who has complex regional pain syndrome type 1 or RSD.
She skyrocketed to stardom. But Paula Abdul claims for each success, she's endured a devastating blow. Despite her fast rise to fame, luck wasn't always on her side. Paula says she suffered a debilitating injury from a cheerleading accident at 17, but decided against surgery, choosing to live with her damaged body. In 1991, she rose to pop star status with platinum hits, but claims she suffered a broken leg in a dance rehearsal. Only 1 year later, she says she endured excruciating neck injuries during a car crash. Then, in 1993, Paula says she was left partially paralyzed after a plane crash, requiring 15 spinal surgeries. Paula reveals the cumulative effect of these injuries began a battle with chronic pain for more than a decade. But Paula put on a brave face for her millions of fans, who never detected the personal hell she was living in silence. Finally, Paula revealed she was given a diagnosis.
I thought that I was doing the right thing by being brave and not telling people that I was suffering from the debilitating nerve disease, and it's called RSD. And by not telling people and thinking that I could make it light and everything like that, you see, it was not the right thing to do. Actually, being really brave would have been to be able to discuss it.
Well, describe the pain to me. I just want to understand what it's like to live through that.
It would start always at my neck, and it would be on the right side primarily, and it would shoot from the base of my neck to my right shoulder, down my right arm. My fingers would lock up, fire, stabbing pain, burning, needles and pins, and a constant, like someone was just poking me all the time, not with a soft object, but a hard one. And it's crazy, but you learn that you learn how to adapt to it, but you learn that it's not normal.
So these patients, in many of them, the presenting primary complaint is going to be pain, and I'll need audio for this one as well.
Any change in the weather cause the pain in all my joints to worsen. Wind sometimes is very painful, just to my skin. Sometimes I couldn't even get up in the morning because I just hurt too much. Sometimes just pressure on any part of my body would cause burning sensations.
What about if cold wind hits your face, what would happen?
It would burn like fire sometimes. Sometimes it would feel like needles in my face.
And did it stay in the face or did it spread out from there?
It spread. It sometimes stayed in the face and head, sometimes spread down my neck into my arms, and sometimes into my two little fingers, all the way throughout my arm.
So another presentation of these patients is muscle dystonia. And this was the very first patient that I recognized CRPS in. I didn't really recognize it. In retrospect, she had it. She presented to me, actually was part of the welcoming committee when I moved to St. Pete. Dawson's practice had saved her for me because she had very esoteric pain. And when she would talk to you, she would talk to you with her jaw deviated to the left with very little vertical opening, and all she complained about was her pain. And so a hallmark of CRPS type 1 is it can begin to impact and create a dystonia and decreased flexibility in the muscles that cross the joints that are impacted by the distribution of the pain. And that contracture can be in the mandible, it can be in the neck, the shoulder, the arm, the elbow, the fingers, and the hand. It can get to the feet if it goes into the lower extremity. And so there's dystonic muscle, and here was Rose. She actually got this from restorative dental work in a tooth cleaning. And very, very difficult to manipulate these people and get a bite registration because of the dystonia. Okay, so really CRPS it's a pain syndrome, but putting that pain syndrome label on it is kind of a misnomer because in some patients the dominant presentation may actually be dystonia of muscles, what I would call sympathetic induced dystonia of the occlusion. In other patients, they'll have an eyelid ptosis like you see here. They get mydriasis or pupillary dilatation. They get a mask of chronic pain. They have decreased muscle animation, what we call a marionette face. And there's altered blood flow and skin discoloration. The skin discoloration is what I call patriotic discoloration. If you're still patriotic, you'll know that's red, white, and blue. And so those are the phases of CRPS type 1. There's a red phase, there's a white phase, there's a blue phase. All of those phases reflect the amount of blood flow to that region of skin discoloration. So that may be the dominating presentation. The other thing that you see is edema. The edema is picked up best in the eyelid and in the pinna of the ear. There's very little space for swelling to go in the ear. So if you've got CRPS type 1 affecting the ear, there's going to be an inflammatory response and edema. And the edema shows up as shiny skin. Okay, they also complain of sweating. And the way the sweating presents is they may get droplets of fluid coming out of their cheek, or what I hear more often is fluid coming out of the ear. But you look in the ear, you don't see anything, but they complain that when they're hurting more, their ears actually have fluid that drains. And so the dominating presentation in some of these patients may be unexplained sweating or edema. These patients also have tissue atrophy. This was a very unfortunate situation. This lady had a Proplast Teflon implant placed into her TM joints. It got infected. And instead of taking that out and sterilizing, the surgeon went back, took the old one out, put a new one in an infected site. So guess what happened? It got infected a second time, and it was after that she started developing complex regional pain syndrome. And what you see on her is what I call cyanotic bruising. And if you look at the dark shadow here around her eye, That's part of this vasoconstriction to the skin. They get thinning of the skin, they get loss of hair, but what's interesting is they get dystrophic nail growth. None of you have experienced this yet, but after you die, your nails keep growing, okay? And so it's very interesting. That's a dystrophic growth that occurs even after death. And these patients with CRPS, this is one of the pathognomonic symptoms or signs that you'll see as a hallmark for this disease. So in some people, it's not pain. The dominating presentation may be tissue atrophy or cutaneous changes. And then another thing that they will get is damage to the immune system. This girl was in a car that had a terrible accident with a semi-truck. She ended up with total body RSD, was in a wheelchair, and as the immune system is altered, their risk of infection starts going up. So the dominating presentation in some patients may be damaged immune system, and you see this particularly in the skin. You can see the skin atrophy, you can see the skin ulceration and breakdown that you can get in these patients. They get livedo reticularis, brawny edema, and shiny skin. You can see the distorted joint here, how the dystonia in the ankle is pulling the foot in. You see the edema in many of these pictures. It looks the same. Wherever it is in the body, wherever it's impacting, it looks the same. Okay, so this is of particular concern following unexpected macro traumas that injure the musculoskeleton, okay? This is where the TMJ comes back into it. If there's an injury to a body part, and if that body part is not appropriately managed, they go from nociceptive pain to inflammatory pain to neuropathic pain. So it is failure to treat a trauma or a physical trauma or injury in a timely manner that many times leads to CRPS. But it may not be that event, it may be the next event that actually turns it on, okay? So sensory pain sources will escalate sympathetic pain patterning. And so when we're treating these patients, the focus is really to treat both sides of this. Now the history of this goes back really to King Charles IX. They practiced bloodletting back in his day in the 16th century, and as a result of letting blood out of his arm, he developed what sounded like RSD in the arm. And that's described in this paper. The real classic paper that had the first presentation of this was written by Silas Weir Mitchell, who's recognized as the father of modern neurology. And he was treating wounded soldiers from the American Civil War. And look what he said. In our early experience of nerve wounds, we met with a small number of men suffering from a pain which they described as burning, or as mustard red hot, or as red hot file rasping the skin. Okay, its intensity varies from the most trivial burning to a state of torture which can hardly be credited, but which reacts to the whole economy until the general health is seriously affected, immune system. The part itself is not alone subject to deep burning sensation, but it becomes exquisitely hyper-aesthetic, so that a touch or a tap of the finger causes pain. Exposure to the air is avoided by the patient with a care which seems absurd, and most of the bad cases keep the hand constantly wet, finding relief in moisture rather than the coolness of the application. As the pain increases, the general sympathy becomes more marked. The temper changes and grows irritable, and the face becomes anxious and has a look of weariness and suffering. The sleep is restless, and the constitutional condition reacting on the wounded limb exacerbates the hyperesthetic state, so that the rattling of a newspaper, a breath of air, the step of another across the ward, the vibrations caused by a military band, or the shock of feet in walking gives rise to an increase in pain. Original description of RSD. Okay, in the literature, you see many more papers here were published. Sudeck was seeing this in Europe and published his classic paper on Sudeck's atrophy. And you can see Livingston talked about the vicious cycle of RSD secondary to disuse. And then Evans coined the term RSD in 1947. Wurz-Hossels described the dystonias. Okay, so the literature is there decades ago describing all the manifestations that we now diagnose with CRPS. So the International Association for the Study of Pain has been the group that has laid out the criteria that have to be followed to make this diagnosis. And you can see the evolution of this. They started in 1993. The actual published initial criteria that are most accepted today were published in 2007. Those are called the Budapest criteria. And then this was re-updated in 2013 with some clarification about CRPS type 1. But if you look at the Budapest criteria, you've got 4 diagnostic categories. And in terms of signs and symptoms, they're supposed to have 2 of the 4 signs when they come into the office. And they're supposed to have a history of 3 out of 4 symptoms. Okay, so these are the diagnostic criteria. And it's based upon satisfaction of the following things. Number 1, continuing pain that is disproportionate to any inciting event. And then symptoms in 4 categories: sensory symptoms, vasomotor symptoms, pseudomotor edema symptoms, and motor or atrophic symptoms, the 4 categories. And then at the time of assessment, you want to find signs in each of those 4 categories. And the key thing is on the bottom line: no other diagnosis that explains the signs and symptoms. So this is a diagnosis by process of elimination of everything else that could be causing the condition, okay? And then you've got your 4 diagnostic categories. Okay, the dental perspective would be as follows. Number 1, neurologists don't get this. And so they won't acknowledge the existence of CRPS type 1 in the face. That's a tremendous disservice to patients. And failure to diagnose this condition early leads to neuropathic centralized pain, okay? So this is a condition that needs to be diagnosed early. And most doctors that are skeptical about this never have an answer as to what it is. Instead, they'll go to the cervical spine and do facet blocks and nerve blocks and all kinds of invasive therapy that basically ignores the fundamental pathology that's keeping this going. And many times that's the TMJ. And many dentists are equally guilty of not looking at the TMJ foundation after an injury to find out if that's the musculoskeletal injury that's keeping this going. And they also don't look at the cervical spine, specifically C1, C2, and C3, to see if the exacerbation point for CRPS is musculoskeletal pain in the neck, okay? So in spite of what many physicians are going to claim, the face with CRPS is well documented in the medical and the dental literature. The other papers were general papers. Now we're going to switch over to papers in the head and neck. This is the last one that I found. It was actually written in 2014. It came out of Europe. This young girl was hit in the face with a snowball. And here's what the author said. The clinical characteristics were similar to those of CRPS elsewhere in the body, involving burning pain, hyperalgesia, and hyperesthesia. This was later accompanied by skin edema, fluctuating color, and temperature changes, as well as loss of eyebrow hair. A clinical diagnosis of CRPS was made in line with Budapest diagnostic criteria. Okay, it's in the medical literature. Here are other medical papers dating back to 1954, documenting CRPS type 1 in the face. I want to draw your attention to Waldman and Hushman. I'm going to talk a lot about Hushman because I knew him personally. We'll talk about the insight that he was getting before 1993. Waldman is here in Kansas City. Very well-respected pain expert, has written multiple books on pain. And he has papers that he's written, listed here, on facial CRPS or RSD. Okay? And again, more papers by Waldman, Arden, Marinus, etc. Now, if you look at the last line here, and this will be in your handout, this was a paper that was written to go back and review the dental literature up to that point on case studies of RSD that were already in the literature up to 2012. I think they ended up with something like 20-some cases that they found. The problem was when they looked at those old cases, they didn't fulfill all the diagnostic criteria because obviously it was before the diagnostic criteria were established by the IASP. And so part of the problem in looking back at RSD CRPS is we have to make certain assumptions that the original authors were correct. It's been a moving target. In other words, now not so much, because now the diagnostic criteria are pretty much set. If you can get a copy, this is a book you're going to want to find. Okay, so this is Hushman's classic textbook on reflex sympathetic dystrophy prevention and management. I'll share some pearls from Hushman out of this book. And as a brief aside, about 25 years ago, I had a patient with facial RSD. I was quite certain of it, and I had no help. I had absolutely no help in management of this condition. So I searched around, and Hushman lives about 120 miles west of me on the other coast of Florida. And so I found him, and I gave him a call one day, and I said, Dr. Hushman, you know, I'm practicing in St. Petersburg, and I have a patient that I would like you to see, and I want you to see her because I know you're an expert in RSD. He goes, well, do you think she's got RSD in her face? And I said, yes, I do. He said, well, you're wrong. It never happens in the face, but I'll see her anyway. So I said, thank you very much. And so the patient went over to see Hushman, and I literally got a phone call the day of the visit. And he goes, now, who are you? And I said, well, I'm just a little Main Street oral surgeon in St. Pete, just trying to do a good job for my patients. And he goes, this is amazing. He said, it is facial RSD. And he said, I have never seen it in my life. He was an RSD expert. All he treated was RSD in the body. And he said, you know, the amazing thing is you were correct. It fulfills the criteria. He said, there's just one thing about it. I said, what's that? He goes, we'll never see another case again. And I said, would you like a few more? Okay. So I sent a few more patients to him, and a very interesting relationship came about. He didn't know much about TMJs. You'll see some of his comments about the TMJ, but he was learning about the TMJ from me. I was learning about CRPS from him. Hushman would give conferences like this, and he would have patient side, doctor side. One big room, nothing but patients. Another big room, nothing but doctors. And I lectured at a number of these, and it was very interesting, the interaction going back and forth from room to room. You know, the doctors kind of, you know, being leery of the patients because they knew they weren't getting better, and the patients looking at the doctors saying, don't you have some kind of a solution for what we're going through? But at any rate, Hushman and I developed a very good working relationship, and I'll kind of show you his insight into things. He felt that the onset or that the way to control and keep from getting CRPS was to have an inhibitory effect on the anterior horn cells, okay, and anterolateral horn cells. And so there has to be a feedback loop of pleasant touch, you know, A beta fiber touch, to create a so-called pleasant sensation that will turn the sympathetics off, okay? And as an example, somebody may cut their wrist by accident, they begin to bleed. There automatically is a sympathetic response that occurs immediately to the blood loss. Everything vasoconstricts to minimize blood loss until the clotting mechanism can take over. And then in the feedback loop, when the clot is there, the sympathetics should turn off. The problem is they stay turned on, and they create this prolonged vasoconstriction, and that's what leads to the tissue damage. And so he felt basically that this condition was perpetuated by a failure of the inhibitory effect on pain and dystonia at the level of the anterior horn cells, okay? And there's a lot of debate about what causes this and so forth, but that's what Hushman proposed. He also talked about the neck. You talk about expanding the envelope. If you want to expand your envelope of practice, you have to know about cervical spine and cervical spine pathology, because there's a tremendous amount of crossover of cervical pain into the face. Here's what Hushman said. Hushman said, cervical spine pathology is quite frequently accompanied by RSD. Trauma to the cervical spine results in referred pain in the distribution of the trigeminal nerve. Okay, cervical spine pathology causes sympathetic dysfunction, Barré-Liu syndrome, which I'll go over with you in a minute. And unfortunately, the role of cervical spine pathology in RSD has been recognized by few clinicians. Published 1993. Okay, RSD may complicate TMJ disease and vice versa. Usually facial injury causes referred pain to the C3-C4 substantia gelatinosa gray matter of the spinal cord. This in turn causes spasm over the deltoid and scalenus muscles. The end result is not only TMJ disease, but shoulder and hand syndrome and thoracic outlet syndrome, okay? The second thing I want you to know about Hushman is his website, and this is still up. Hushman's disabled and retired. He kept his website up. The website is rsdrx.com. And if you go to his website, you'll find a page in there that talks about puzzles. And the puzzles are very interesting. These are questions posed by patients and answers given back by Hushman. And it's very conversational. It's very matter of fact. It's very, very clear how he felt about things and how he communicated some of these problems back to the patients. So here's what he says. This is puzzle number 3. It's titled RSD and TMJ pain. Okay, as remote and unrelated as they may seem, RSD can and does result in cranial cervical pain, muscle spasm, TMJ disease, and deterioration of the teeth. One common manifestation of RSD in response to pain is muscle spasm and motor dysfunction. This can be in the form of flexion deformity of the extremity, difficulty with walking, flexor withdrawal of the muscles of the extremity, and lumbar and cervical paraspinal spasm. As a result, the patient develops muscle tension headaches, as well as spread of the muscle spasm to the facial muscles, with resultant stress on the temporomandibular joint and severe pain and spasm around the TMJ. Okay? Also, answer under puzzle number 3. With passage of time, they get chronic TMJ pain. The patient develops severe pain in the distribution of the trigeminal nerve, sensory nerve for the face, and develops moderate migrainous vascular headaches, trigeminal vascular headaches. In later stages of RSD, the immune system becomes disturbed, and the patient develops poor oral hygiene and dental deterioration. As a result, a revert pain develops with resultant facial pain and secondary muscle spasm around the TMJ and jaw. The same referred pain causes migraine headaches, TMJ pain, and chronic stress on the teeth. Okay, puzzle number 42. Craniofacial RSD and root canal procedures. Once the RSD spreads to the orofacial region, it causes necrosis of the maxillary and mandibular bones in the areas of the root canals. At the present time, what you have is a vicious circle of RSD causing bone degeneration in the face, aggravated by unnecessary root canal explorations. So if it's RSD, especially pre-necrotic, and you do a surgical procedure without controlling the RSD, you exacerbate the vasoconstriction and the inflammatory pain and the swelling and the localized hypoxia and the tissue necrosis. And then it spreads to the next tooth, or to the quadrant of the mouth, or the whole side of the face, or to the face, neck, shoulder, and arm, or the whole side of the body, or it crosses over the coccyx and goes to the other side of the body. This is CRPS, okay? Puzzle number 42, craniofacial RSD and root canal procedures. These are nothing but the side effects of RSD causing inflammation, lack of circulation, and death of nerve and bone tissues. It is best not to keep digging into the area surgically because it only aggravates the condition. Very, very anti-surgery. Okay? The third question that you have is in regard to the fact that already your immune system has fallen apart. This is a lady who started with dental work and ended up going to Hushman because of her trauma from the dental work. And again, I'm not being critical of the dental work. It was the threshold event that caused this. And it changes your abnormal or creates abnormality in the T-cell regulatory function of the body. Okay? And he went on to say, of course you're going to have headaches. You know, it's your RSD and you've got to take care of it. And he said this down here. Please do not forget, it is your decision, it is your life, it is your mouth, it is your head, It is your RSD, and do not let anybody approach you with a knife again. Now, I had to give him a call, okay? Because he was saying that to TMJ patients too. I happened to have at that time a TMJ patient who had a bony ankylosis of her TMJ. And ankylosis in the TMJ very oftentimes is a result of this entity. With the hypoxia is an increased tendency for scar tissue formation. Simpler scar is fibrous scar, more complicated scar is heterotopic or dystrophic bone. So some of these patients will actually freeze their TMJ from bone overgrowth. I had one of these patients, and I said, you know, I've got to operate on this patient. He goes, no, you can't. He said, every time he's had a patient operated on, they've gotten worse. And I said, yes, but this patient's facial pain is making her CRPS worse. And so he conceded, and he said, okay, one condition. He said, if you're going to operate on her, she must be seeing me at the same time, traveling across Florida to see him for sympathetic blocks. He did a lot of third-order ganglion blocks. So anyway, I agreed to that, operated on the patient. The patient got better. Okay, fat grafts are a staple in my practice. And fat grafts are nice because they become a myelin substitute around non-myelinated nerves. And at least that's my theory. And so this patient had a marked reduction in her sensory pain by putting fat into her temporomandibular joints. And Hushman was now able to get her CRPS under control. And he called me back and he said, this is amazing. He said, it's the first time I've ever seen a patient with surgery get better. And I said, I think we need to try a few more, okay, which we did. And the tables turned. What was very interesting was instead of me sending patients to Hushman started sending patients to me because he understood the value of treating the musculoskeletal injury. And by treating the musculoskeletal injury, it was taking away that source of pain that was exacerbating the CRPS type 1. So a whole new phase of management basically grew out of this concept of being very negative about treatment. Okay, he goes on to say in RSD in the mouth, the sympathetic nerves that provide sensation of pain and provide control of circulation of the soft tissue of the face and mouth are damaged, and the patient develops stabbing, burning, or electric shock of pain with a tendency for recurring frequently. Okay, and again, he was anti-surgery, but he was anti-one more thing, and that's ice, anti-ice. You don't ice these patients after a new trauma. Ice vasoconstricts. It becomes part of the breakdown process, part of the persistence of the edema. You have to get away from ice, and even short periods of ice he was very, very much against. And so ice exposure is something that normally doesn't result in pain, but when it does, we call that an allodynia. In this case, a dental allodynia from CRPS type 1. And again, I acknowledge there are other ways that you can get dental pulpal pain. Obviously, a pulp exposure is going to cause pulpal pain. That's a known cause. In CRPS, we rule out those known causes and we say, okay, you've got dental pulpal pain, and that pain spreads beyond the tooth. And so the treatment is not to repeat the root canal, or to give them a root canal, because that will fail. And guess what they do? They repeat it again. And sometimes they repeat it another time, and then they always get this diagnosis. Well, you must have a cracked root. So the tooth is extracted, and guess what happens? The pain spreads to the next tooth. They may start the same process in the next tooth and repeat the root canal and extract the tooth, and then it's the whole quadrant. That's CRPS, okay? That's a progression of pain that's out of proportion to the initiating event. And you don't have something that otherwise explains the pain, and it all gets back to making that diagnosis of dental allodynia at an early point in time. And again, Nick's done a beautiful job of treating these patients. And I really look forward to his presentation because he's gonna tell you that part of the puzzle, okay? So allodynia or stimulation from cold leads to over-treatment of the dental pulp. And I'm not here saying don't do root canals. If there's an infection, you have to do the root canal and crypts, or else the infection is going to make the crypts worse too. You have to make a good diagnosis. You have to know diagnostically through your imaging and your testing and your laboratory studies that you know exactly what this is. And by process of elimination, you come up with crypts. I talked about Waldman earlier. 2 classic books that I'm going to recommend you buy. Waldman wrote, and there's one more edition beyond this one. He wrote many, many books, but this one is Atlas of Common Pain Syndromes. The parallel book was Atlas of Uncommon Pain Syndromes. Guess where he put facial RSD? It's in this book, Atlas of Common Pain Syndromes. And he knew about it because he had published it, because he had done stellate blocks and watched for the effect of it. So this is a classic book, and in the book, he has a classic description of CRPS in the face. And I credit him too with being one of the early pioneers to buck the system, in his case, pain management specialists, and to say, yeah, it does occur in the face. And I've seen it, and I've treated it, and I've published it, okay? I want you to know about Barré-Liu syndrome. So if a pain specialist says, oh no, CRPS doesn't occur in the face, then my response to them is, okay, it's probably Barré-Liu syndrome. And of course, they're always smarter than I am, and so they don't admit that they don't know what this is. But what it is a pain syndrome originally described in 1925 by Barré. And then the Chinese doctor, Liu, described it in 1928. And then it was picked up by another doctor, Gabriel, and Gabriel published a paper acknowledging these 2 papers decades earlier, and he called it Barré-Liu syndrome. Look at what this is, and think about how often you see this. Symptoms include tinnitus, vertigo, dizziness, nausea, vomiting, blurred vision, tearing of the eyes and sinus congestion. They may get swelling on one side of the face, localized cyanosis of the face, facial numbness, hoarseness, shoulder pain, dysesthesias of the hands and forearms, muscle weakness, and fatigue. Barré-Liu syndrome, if you want to read the paper on it, this is the one that Gabriel wrote in 1947 and published in the Lancet, okay? So this is in the medical literature. Is it possible, though, that we're just really part of that spectrum? Well, it was described in 1925, originally by Barré. It may just be part of what I'm standing here talking to you about today, okay? We're almost 100 years into good publications with this particular type of problem. Okay, so how are we going to diagnose it, okay? So diagnosis is basically going to be application of Budapest criteria, okay? So I'm going to take you back to this paper that was the update in 2013. And so the diagnostic categories: continuing pain disproportionate to the inciting event. They've got to have a symptom in the 4 diagnostic categories: sensory, vasomotor, pseudomotor, and motor. Then they've also got to have a sign, 2 signs, or signs in 2 areas at the time of presentation. Same 4 diagnostic categories, and the bottom line is the important one: no other diagnosis that explains it. Now, they don't know about dental problems. So if you were to extrapolate Budapest criteria to the oral facial region, these are things you would come up with. Hyperalgesia, the pain processing part of this. Hyperalgesia, hyperesthesia, allodynia. The hyperalgesia would be non-dermatomal, facial or cervical burning, stabbing pain, unexplained tooth or mucosal pain. Diagnostic category number 2, hyperesthesia. Hyperesthesia is an increased response of any sense. So you could get hyperacusis, which is sensitivity to loud noise. You could get photo hypersensitivity. They wear sunglasses because lights are too bright for them. They get an increased response to touch or injections. And they have what we call the 1-inch sign. The 1-inch sign is, don't come in 1 inch of touching me or I'll kick you know where, okay? Now they can take their finger, they can dig it in really hard, and it doesn't hurt them as much as you touching them lightly. And that's called reverse wiring of CRPS type 1. So they have hyperesthesia, they have allodynia as the third category. And they don't have to have all of these, they just have to have one in this group. Second group, vasomotor symptoms. Temperature asymmetry, it's typically 1 degree or more between one side of the body and the other. It could be between the forehead and the mandible. It could be left face versus right face. 1 degree difference or more represents a significant vasoconstriction where the skin temperature is cooler, okay? And the place where it really comes out, and a lot of these symptoms come out, would be in the fingers, okay? And they have skin color changes that you'll know too, the splotchiness in the face, the patriotic discoloration, and so forth. So they just have to have one thing in this whole category. Next category, pseudomotor, and just remember that's swelling and sweating, okay? So you're looking for swelling. Do they have edema that you can see, or do they have a history of edema, which could be sinus edema. It could be nasal congestion. It could be decreased hearing from edema in the ear. The edema is generalized, the CRPS type 1 is generalized, and then sweating. Okay, they actually have more axillary sweating one side than the other when the RSD spreads into the upper extremity. And then the motor signs, they almost all have this. They have trismus. You ask them to open their mandible, and they have a really hard time initiating movement. They have to think about it for a few seconds before they can open their jaw. Or you say, move left and right. They have to think really hard to make it move left and right, and when they move, the movement is ratcheting. We call that perseveration of movement, okay? And the other thing that you'll notice is that if they walk in with the dystonia, and the dystonia is in all the muscles of emancipation. So dystonia of the elevator muscles makes those shorten down. That's the trismus. That's why they can't open vertically. But the dystonia in the lateral pterygoid muscle creates a mandibular protrusion. And the protrusion, if it's one side, that side will have contraction of the lateral pterygoid. The mandible will deviate to the opposite side. Okay? So this is the dystonia that you see in the muscle, and the motor dysfunction that you see in the muscle as well. Okay, we'll talk about the response of this when we actually do nerve blocks. So you have to have signs in 2 to 4 major categories. Okay, and again, here are the 4 categories, and those are signs, things you see at the time of presentation. And then they also have to have 3 out of 4 symptoms at some time prior to the visit, and so it'd be the same diagnostic categories. So here are my pearls. My pearls are for the hyperesthesia or allodynia, the pain processing part of this diagnosis. Most commonly, this is in teeth or the joint. And burning pain is pathognomonic of CRPS type 1 RSD. Okay? The second is the vasomotor. This is color change and asymmetry. And you're going to see this most frequently in the fingers, and you check the microcirculation. And that's done by simply compressing the pad of the index finger. And what I'll do is I'll put my finger next to the patient's, and I'll compress them both at the same time and watch how the capillaries refill. If they're vasoconstricted, capillary refill is slower. Now, I'm an old man, and if I can beat a 20-year-old, there's something wrong with the circulation in that 20-year-old patient, okay? But it's a simple way of looking at the vasoconstriction response. They also will have a Raynaud's type phenomenon that they'll describe in their fingers. Raynaud's may be a risk factor for this problem, but their Raynaud's will be worse. In other words, they're going to vasoconstrict in their fingers and hands when they're exposed to cold. And you look for that constriction when you look at it. The pseudomotor, the edema, ears and eyes. So edema spreads out readily periorbitally. Edema also is visualized in the pinna of the ear because it turns shiny. Okay, if I'm looking post-TMJ surgery at a sympathetic response, I'm looking at a shiny ear. I don't care about their pain. If they've got a shiny ear, I'm going to do a sympathetic block. We're going to turn that back off again. I'll show you what those blocks are here in a minute. Okay, they may have gingivitis or mucosal edema, and in the edema, the pulp is probably the most misdiagnosed part of this. Okay, so that's third diagnostic category. The fourth one is the dystonia that we've talked about. Difficulty initiating movement, lateral deviation, bilateral protrusion. With bilateral protrusion, they tend to be more premature on their anterior teeth if they have anterior guidance. Okay, and that's the presentation. And you try to set their bite, and it's variable because the spasm is variable, the bite relationship is variable. Establishing a bite registration for restorative or an endpoint treating the occlusion is very, very difficult. Okay, so in the immune system, a brief overview on this. Here's a classic paper, one you may want to get. Neurotransmitters released by sympathetic and parasympathetic nerve endings bind to their respective receptors located on the surface of immune cells and initiate immune modulatory responses. And both sides of the autonomic nervous system are regulatory in that regard. That's Kenny's paper. Okay, here's Hushman. Okay, first 2 years, and some people say 6 months. Hushman said 2 years. The immune system is upregulated. You have higher levels of T cell lymphocytes. Okay, now that eventually fails. And after the first 2 years, you then get an elevation of killer T cells. Okay, so the more chronic this neuroinflammation, the more the immune system is now regulated to the point that you put the patient at risk for pruritus, neurodermatitis, persistent trophic ulcers, like I showed you in the photographs, spontaneous bruising, and permanent dystrophic changes, especially in the subcutaneous tissues of the skin. Okay, some of these patients walk in, they have no subcutaneous tissue, especially if they've had an artificial joint. If they've had an artificial joint and they get CRPS after placement, it looks like the skin is covering the skeleton. There's no meat in between. Okay, that's the atrophic process that they get into. And Hushman was negative about all these things. Unnecessary surgery. He actually changed this after he and I worked for a while. Alcohol, narcotics, and addicting benzodiazepines. Now he distinguished between Valium, which is a more addicting benzodiazepine, and Klonopin/Ativan, which are less addicting benzodiazepines. Okay, so he wasn't anti-benzodiazepine, he was anti the more addictive ones. Distress from legal entanglement, these people sue you a lot, okay? And legal entanglement is a big part of their presentation, it's part of their stress that also drives this condition. Inactivity, lack of exercise will drive CRPS. Lack of touch, they should touch the body part to basically stimulate the A-beta fibers. And if they'll do that, they'll get a better feedback loop to stopping the CRPS type 1. And then hot dogs, I guess you didn't like hot dogs, and then ice on the extremity because of the vasoconstriction from the ice. Okay, etiology. For the etiology, a couple of classic papers. This one says 90% of patients with CRPS have a history of an initiating noxious event, and that would be trauma, ischemia, or nerve compression. It's not clear why everybody doesn't get it, and there's no single pathophysiologic mechanism that can explain the diversity and the heterogeneity of the symptoms, okay? That's why it's a syndrome, okay? You don't have one explanation that is nice and tidy and pulls everything together, okay? But trauma is a big part of it. So your burden is to take a good trauma history. And I'll have more on that in a little bit. If you ignore trauma, and I believe I'm correct in this, or somebody will check me, the OPERA study of TMD patients, you know what one of the main exclusion criteria was? No history of trauma. To me, that's crazy. Okay, we've got a major study looking at TMD and looking at how this progresses, and we exclude trauma, which is a big part of CRPS. And in my world, a big part of what I end up treating in terms of musculoskeletal problems. Risk factors, I've highlighted a couple of these. Persistent noxious input from tissue damage, nerve injury mediated by neural peptides like substance P and bradykinin, both from the C-spine and the temporomandibular joint. Okay, tissue injury. And the last one's interesting because I've been very anti-psychological input into pain patterning in TMJ patients. This actually explains and opens that world. So the way that you perceive the pain after it's transmitted to the brain is part of the psychological part of this, and that's why reconditioning the brain and the response to the pain is beneficial. So now I'm back on board, but I don't look at that as the etiology for a patient who's got torn discs and necrosis of their condyle, okay? So psychological forms, and Brule has been a big contributor to the IASP, and this was Brule's paper where that was published. Now let's take a look at diagnostic screening, laboratory testing, imaging, and nerve blocks, okay? So right up front, CRPS is a clinical diagnosis. There is no specific diagnostic test, okay? Testing, however, is necessary because it's adjunctive to rule out other things. And you have to do any appropriate diagnostic imaging to rule out other disorders reasonably within the differential diagnosis, okay? So you've got to do some form of testing. You won't do everything I'm going to go through, but I want you to think real hard about, if you are getting a cone beam, think real hard about how you could apply some of the pearls of what you learned from a cone beam to this diagnosis, or ruling out other things to come to this diagnosis. And if I can take you into the world of MR, which, by the way, has now been commonly available for 30 years. 30 years. Ask Cliff Simmons how long MRI has been around. 30 years. And most dentists still don't use it. You're going to miss a lot by not doing MR scans where indicated. So, radiography. Studies show that if you're taking a radiograph, periauricular or periarticular osteopenia, especially in long bones, and patchy osteoporosis can be seen within 2 weeks. So there's implication for bone density, and you get a regionalized osteoporosis. Okay, in the head and neck area on cone beam, I'm looking for that regionalized osteoporosis in 2 spots. Vertebral bodies of the cervical spine. You see them? You might as well take advantage of looking at bone density. The second area is going to be in the ramus body of the mandible, and in particular at the bone density of the inferior alveolar nerve canal. When you begin to lose the canal on your imaging, that's a sign of marked osteopenia or osteoporosis in the mandible, okay? The head of the condyle will also show a regionalized osteopenia from CRPS. CT. Okay, I use CT in general to rule out other conditions. Tumors, cervical spine disease, and I'll show you a CT of how I do the cuts. Sinus disorders and dental pathology. Okay, and then MR. MR is not just the TM joint. When we're doing an MRI scan, we're looking at the lower 20% of the brain. We're looking through the skull base, we're looking at the pituitary, we're looking at the inner ear and the deep facial structures in the upper half of the face. So you've got a lot of geography that you can cover with a magnetic resonance scan to look for other pathology when you've got a patient with chronic pain. Bone densitometry, that's a little bit of specialized testing, but that can be done. Harder to do in the mandible. Thermography. Okay, thermography was used a lot by Hushman, and Rowe wrote this paper. Thermography is a way of measuring skin temperature, and basically what happens is the patient has to equilibrate their skin temperature in a room that's a set temperature. They have to sit in this room naked for like 30 minutes. And then these sensors are shining across to the body to pick up differences in body temperature from one region to another. So if you get more than 1 degree difference, that's pretty much diagnostic that you're vasoconstricted in that area. I used to do a poor man's form of this, which was actually surface thermography. And it's kind of like the little rubber things that they used to sell. You put your hand on them and it would change color. That's thermography. And they had different temperature ranges for the head and neck area, and we were trying to do that diagnostically in the head and neck, but either I was too stupid or it was too crude and really couldn't figure much out from it. Cushman actually had the digital version with the sensor not touching the body but away from the body, where he could very, very accurately measure skin temperature. Sweat testing. Okay, sweat testing can be a starch test. And again, sweating is increased in CRPS. The other thing is what's called a Q-SART. And a Q-SART is provocative testing of the autonomic nervous system to induce sweating. And very sophisticated machinery. And so you have to have a cholinergic challenge. And then this machine can measure the sweat output in different parts of the body. Many neurologists will do Q-SART tests to look for complex regional pain syndrome. Nerve conduction studies can use to differentiate between different types of nerve injury, in particular a crush injury or a compression injury to a nerve versus CRPS, which should show better conduction of the nerve itself. And then laboratory studies, I've highlighted 3 things. The inflammatory side of this pain pattern can be significant. That's why we want to do a SED rate and a C-reactive protein. C-reactive protein has a half-life of 19 hours. And so if you have an ongoing inflammatory state in the body and C-reactive protein remains elevated, you know you've got a chronic inflammatory condition, which this is. And then the other is specialized testing like a hemoglobin A1C. Here you're looking for control of diabetics and potential for diabetic neuropathy. Remember, you're ruling out other things to say it's not this, it is CRPS. And a hemoglobin A1C may be something you may have to look at if you've got a patient who's diabetic. Okay, and then the diagnostic screening, you must have a complete medical trauma and dental history. How many times have you heard that? What is that? Well, that's working really hard to figure out what's going on. And what you really want to look for is what's called a threshold event. And a threshold event, I run a big database. What we found in our database was that the threshold event seemingly was trauma number 3 in a thermatome of the body. So the thermatome in question would be head, neck, shoulder, arm, one side. That's one thermatome. Head, neck, shoulder, arm is a thermatome on the other side. You look for 3 traumas in the thermatome, and they could be separated by years. So trauma number 1 might be wisdom teeth coming out at age 16, and they got a dry socket. Okay, that healed up. Took a while, but it healed up. And then when they're learning to drive, they're 17 or 18, and they have a whiplash injury to their neck. And they get into extended pain for several months, but then it gets better. And then trauma number 3, you decide you're going to do veneers on their maxillary incisors or maxillary anterior teeth. And after the veneers, boom! They've got this unbelievable extension of pain way out of proportion to your procedure. And you look at them and you go, you're crazy. There's no way my procedure made you get this pain. No, yes, it does happen that way. That dental procedure is the threshold event. And the reason you want to take a good trauma history is so you have an understanding of that. I take a trauma history in all the surgery patients. It's risk profiling the possibility that they're going to get CRPS type 1 when I do joint preservation surgery. And I don't want that. Okay, I take pride in not getting that kind of reaction because I'm reacting to it before it happens. And that comes from the trauma history. You want to rule out pathology, or you want to rule out other things in the periodontium and the teeth, but a pearl is that they get osseous atrophy in the periodontium. So they have generalized premature periodontal bone loss. I'll see a lot of young people with furcation involvement from periodontal bone loss from chronic hypoxia in this region of the body. And then you want to screen the cervical spine and sinuses and other areas for potential pathology. So look at this patient. And I'm sure you all have an impression right now about what's going on with this patient. And we probably look at her, and before I tell you anything about her, we probably have many different perspectives on what's most important. I'll give you a little background. She came in to see me as a TMJ patient, so she had pain, okay? She also had multiple prior traumas, so pain and multiple prior traumas. And if you look at her face, she's asymmetrical. You look at her cervical spine, she's forward head postured. You know, it looks like a significant neck problem. So if you're a chiropractor, you're saying, well, this patient's got all of her problems because of her neck. And if you're a TMJ expert or a bite expert, you may be saying, well, no, she's got a TMJ problem. Or you may be an airway expert and say, well, no, all of this is from the airway, and she didn't suckle right as a baby. Okay? We all look at them differently. This young lady is daughter of a chiropractor. Okay? Now let's look a little bit deeper. Here is her bite. She's 27 years old at this point, I think. Look at her bite. Significant wear. She's got an anterior open bite. Looks like a tongue thrust, doesn't it? Looks like a tongue thrust, but you know, I record bites 3 ways because the bite reflects the joint. The way the bites are recorded, they're recorded in MIP, and then I bimanually manipulate and I seat the condyles and I register that seated position in a small blue moose bite, and we take a picture of that. And you can see the difference. The joints are compressible between MIP and fully seated. And then the last row is incisal edge position. She can't get them together anymore, but there's wear. And so this lady's bite gives us insight that things have changed. I remember previously I said endotyping the occlusion. If I had seen her 10 years before, I may have endotyped her as an angle class 2 unstable TMJ, because it's the TMJ that has caused this deformity. And part of the reason I say that is because when you then get to the underlying structure, I would pose this question. Why is the ramus on the right side 61 millimeters and the ramus on the left side is 50? Okay? There is marked asymmetry to the mandible, and that marked asymmetry is not the airway. This asymmetry is contusion to the left temporomandibular joint during active growth. Nebby's written a number of papers on this, and she failed to grow on the left side. Okay? Her nociceptive pain was never addressed, and it spread, and she eventually developed CRPS type 1. So look at the left condyle. It's flat, but it's well corticated. Look at the right condyle. The right condyle is larger, it's compressing at the lateral pole, and it's very irregular. This is a condyle that's breaking down. Okay, so from the CBCT, you would look at the panoramic cut and say, well, her problem's on the left. Not today. Today the problem is on her right, because she's getting a transverse strain to the right TMJ because the left side was never treated. Okay? The transverse strain, when you have a small condyle, is the other condyle shifts laterally, and it knocks the disc off the lateral pole. That disc goes medial, and if they're in the wrong set of circumstances and have CRPS type 1 layered on top of it, they begin to undergo bone degeneration. This is the CT side of bone degeneration here. Here's her cervical spine. Okay, she actually has a tendency for an anterolisthesis of C3 on C4. And remember, we're thinking about cervical plexus, C2, C3, C4, for giving us cutaneous pain and sympathetic altered output into the face. She's got a messed up neck, and her dad's a chiropractor, okay? And if you look further at her neck, you see this. This is the tendency toward an anterolisthesis right here, C3 to C4. She's got some regionalized osteopenia in this bone. Okay, you look further. The odontoid process is asymmetrical with C1. Okay, there's ligament laxity in the spine. When you look at the spinal processes of C2 through C6, she has a scoliosis in the neck. And the main assessment on the cervical spine that I'll drop to you as a pearl is you want to look at C1 and C2. So this is C0. This is the skull base, okay? And in an axial perspective, you want to have this really symmetrical. And then you extend your cut to include C1. C1 is right laterally shifted and posteriorly rotated. C1 is not supposed to laterally shift. C1 is letting us nod, okay? It's not supposed to have a lateral shift. This is a source of significant cervicogenic pain that then creates an exacerbation of TMJ pain. So guess what you would end up doing in this patient? You would say, you've got to see a chiropractor, and there's more of the story when you look at C2. C2 is now rotated the opposite direction. Its spinous process is now shifting to the right. Vertebral artery is trying to go through the foramen in the lateral or in the transverse process, and you've got vertebral artery instability from her instability in her cervical spine. It's not just a TMJ problem. Her macro trauma that injured her TMJ, injured her spine. Those pain patterns started out as nociceptive, then inflammatory pain, not treated adequately and early, and became neuropathic and centralized pain, okay? Here's your MRI. I told you on the CT, the left condyle is small, but it's not breaking down. How do I know? Well, she's got a good cortex on CT. The other way I know is from these two pictures right here. This one is a fat signal. It's called a T1 scan. You do a T1 scan in the mandibular condyle to look at fat signal. Fat is basically going to give you input into damage in the bone marrow. Fat's the hardest thing to kill. And so if fat cells are dead, you interpolate that blood cells and bone cells are also dead. There's no fall off in fat signal. That doesn't mean she wouldn't have early necrosis, possibly, but she's not likely to. The second thing here is the T2 scan, and a specialized form of that here called a stir. T2 and stir, you're looking for fluid. So if you've got acute marrow breakdown, you're going to have a higher fluid content in the bone, okay? And it would be brighter gray or white in the condylar head. So the left side, the one that's smallest, the one that has what I call an osteochondral growth defect from a childhood injury. Basically, her disc was dislocated from a childhood trauma. The apex of the condyle stopped growing. And so ramus height on the left side was diminished. That's the childhood part of this picture. Okay, now that condyle is stable. Okay, she's adapting to the dislocated disc. But now I want you to look at the right side when I bring up the fat signal and the fluid signal on the right side. The fat signal is showing increased fluid at the apex of the condyle, which is right underneath the area that was looking eroded on the CT. Okay, so this is confirmation on the MR side that that fuzzy surface on the CT indeed is inside-out breakdown, avascular necrosis. And the other subtlety is when you look really carefully at the apex of the condyle, the fat signal is dropping in the subarticular marrow. So this is a necrotic condyle very early. And this probably is occurring in part because of the mechanical strain and also in part because of the CRPS type 1. So the value of imaging is that we get to look at a whole lot more. I'm going to draw your attention to one more thing. I want you to look at the ear, the stir sagittal view of the ear on the left side. Okay? Now I'm going to show you the stir sagittal ear on the right side. What do you see? Marked increase in generalized edema. And what this is a CRPS type 1 reaction, not just in the bone, but in the soft tissue. Swelling and sweating asymmetry. Hallmark of CRPS type 1. Now this is where, if we're lucky, we pick up a picture that shows us this. We don't always pick up this clear picture with this amount of edema, but this patient had it. Okay, so RSD, CRPS type 1, can be maintained by musculoskeletal mechanical injury in the distribution of the painful thermatome. It could be the neck, it could be the jaw, it could be untreated bite problems, it could be dental pathology, it could be sinus disease, it could be an infection, it doesn't matter what it is. I've had patients come to me with facial crypts after a facelift. I've had them come to me with facial crypts after many different types of dental procedure, dental implants, total joint replacement, sinus surgery, nasal surgery, popping zits, it doesn't matter. They get CRPS type 1 when the threshold event actually creates the pain patterning. Okay, and they can get into a wind-up loop between the sensory side and the sympathetic side. So what we want to do on these patients is nerve blocking, and we want to try to put this condition into remission. There are 4 nerve blocks that can be done to sort out different types of pain. And so I basically think in terms of systems of pain: trigeminal system, cervical system, and cervical sympathetic system. Okay, and the nerve blocks will help us address each one of them. When we're blocking in the neck, Erb's point is the key anatomical landmark. Erb's point is the place where the cutaneous nerves from the cervical plexus cross over from the back margin of the sternocleidomastoid muscle and spread out from there to the skin. So at Erb's point, if you go all the way down here and walk along the posterior border, you're going to get basically the greater auricular nerve, the lesser occipital nerve. You're also going to get the transverse cervical nerve, and you're going to get the supraclavicular nerves. Now, if you want to isolate just the greater auricular nerve, you can actually come above Erb's point, right at the angle of the mandible, and infiltrate local anesthetic right there. Many times dentists are comfortable doing that. I recommend staying above the muscle and not below the muscle, because if you go below the muscle, you're now possibly hitting the phrenic nerve, which is C3, C4, C5, which keeps your diaphragm alive, okay? And you don't want to knock their diaphragm out. So superficial to the muscle, you're safe. Deep to the muscle, the patient may have a little bit of breathing problem. And the pinna of the ear is actually a good source for sorting out pain. Look at this distribution. Most of the ear is actually innervated by the cervical spine, by the greater auricular nerve. It's only the anterior superior part of the pinna that's innervated by the trigeminal nerve, and then the ear canal is actually innervated in part by cranial nerves 7, 9, and 10. In fact, when you scratch the inside of the ear canal, it makes them cough. That's Arnold's nerve, which is a branch of the vagus, and that's why ear stimulation makes somebody cough, because it's going right to the vagus and the parapharynx, okay? So endotyping with diagnostic nerve blocks, here's the first block, okay? And in the first block, you're going to sort out the masticatory system part of this D3. This is an auriculotemporal nerve block. Every dentist should know how to do this. It's not that difficult. It's done from the outside of the skin. You're about 1 centimeter down from the apex of the condyle, and it happens to also be about 1 centimeter down from the mid part of the tragus. I actually have the patient open a little bit, and I infiltrate along the posterior part of the mandible. This is 90% of the pain supply to the TMJ. As you all know from Hilton's Law, when there's mechanical injury in a joint, the muscles that cross that joint go into spasm. If they have muscle spasm secondary to a joint injury, when you block this nerve, the muscle spasm releases. It helps them with trismus. They'll open better. What may be left over are trigger points. And the trigger points are typically in the temporalis muscle. Anterior fibers are just above the arch. Those will still hurt, but they'll open better if it's the joint. Okay, the second block, sorting out dorsal cervical pain. The primary block is greater occipital nerve. And basically, this again is a very easy block to give. You're going to find the most tender spot in the occipital groove, compress it with your finger. That's where the greater occipital nerve crosses the skull base and comes up the back of the head. This nerve will give people headaches at the occiput, the skull vertex, and in the retroorbital area. When you block this nerve, you're also blocking sympathetics that are going with the nerve, so you can actually get a fairly extended relief of headaches. But that's checking dorsal nerves. The ventral nerve, I'll show you here in a minute. But before we get to that, let me show you what a second order neuron block is like when that's done at the stellate ganglion. Basically what you have to do, you have to be careful and miss the vertebral artery, go to the transverse process of C7, And you're going to inject right there because that's where the sympathetic chain is crossing the cervical spine. This is going to block all the sympathetics from third ganglion to second to the superior cervical ganglion. This is called a stellate block. It's the more generalized block. We do fewer of these now because what I have found is that especially for oral facial pain, if we go to the cervical plexus and we pick the greater auricular nerve and block this is going to give us the similar amount of relief in the face that we get with the stellate, and it's a lot safer block, okay? And let me tell you what I've seen respond to this block. Number one, the patient you can't get numb, this gets them numb too, okay? Number two, dry sockets. I have blocked patients with dry sockets, and guess what? Pain goes away like that, okay? Post-operative escalated pain, anything that's above a 5. If they've got pain above a 5, I'm saying it's sympathetic pain, I do this block. And in the week patients are with me after surgery, I may block this 3 or 4 times. And it's to wind the pain down so they don't get into the transduction of pain up to the spinal cord. Okay, so this is a very common block. This is the block I think every dentist who deals with facial pain, trismus, what they think is TMJ pain, sorting through dental pain, every doctor in this audience should know how to do this block. Nick has watched this in my office. He's visited me, and I've seen his results with his patients. I'm very interested in what he's going to share with you in the next talk. Okay, if I could have the sound on.
The block I'm thinking of is actually a neck block, and what it does is it gets cervical pain fibers that refer into the face. And it also includes some of the sympathetic nerves that are involved with CRPS. And so I'd be very interested to know what that kind of block would do for your pain. And the way this would work is I'll give you the block, and within a minute or so, you just tell me if you feel any better, if you feel better, where that improvement is going on. And I'm using a tiny needle here, and we'll see if that doesn't work a little bit better for you, okay? All right, you doing okay with that? I'm getting a little bit of a sting now. How is that? Is that too unpleasant, or are you doing okay with it?
I'm okay.
Okay, that's great. I'm going to put a little bit of this in right here. I'm going to switch this, and we're going to come in the other way. So let me ask you this. If you try to open your jaw widely, remember how that felt earlier today?
Mm-hmm.
What happens when you do that now? Is there any difference, or is it the same as it was?
That feels much, I don't feel, it doesn't feel as painful.
And what you're talking about is this morning when I examined you, I took your head and I just put light pressure on it, about like that.
Right, and that's not bothering me like it was this morning.
But this morning it escalated pain all the way up through your face, didn't it?
Yes.
If you tap your teeth, are they sore?
No.
Or do they feel any different?
They don't, I was feeling pain, like a shooting pain in my bottom 2 teeth when I would tap them together, and
Can you make it shoot? Can you do anything to make that hurt?
That doesn't seem to hurt like it was earlier.
Can you remember this morning I manipulated your jaw?
Yes, and I've been spending the whole day, and I have a lot of trouble with the shifting my jaw, the left to right motion. It's extremely difficult.
What about now?
That was much easier, and I didn't feel the same.
So that's what a block looks like. So I have about 20 minutes of material for the next 13 minutes, so I'm going to pick up the speed a little bit. Concepts of treatment. We've tried all kinds of things from a conservative standpoint. Paraffin therapy, where you dip the hands in paraffin bath. And my physical therapist used to do a lot of this for upper quadrant RSD. Magnesium sulfate, Epsom salt came out of Epsom, England, for those who don't know that trivia, and it's claimed to reduce edema. Studies indicate that it's very difficult because of the cutaneous layer. It's very difficult for it to penetrate into the body, but they did find this one pearl. It may penetrate through hair follicles, okay? So Epsom salt's up in the air. We make people touch and move. Lack of movement creates more RSDs. They must move. One therapeutic thing that I now do is I make them sweat through activity. So I want them to sweat every day. They don't have to keep sweating, they just have to sweat once, or if they want to do it more than that, they can. You're training the sympathetics to do what they typically should be doing. You want to do a melatonin repair if you can, and there's conflicting stuff with melatonin and sleep in these patients. Younger people are going to be more reactive to melatonin. With prolonged sympathetic discharge, you're going to manufacture more melatonin because that beacon coming off of the superior cervical ganglion goes directly to the pineal gland. Younger people are more sensitive to melatonin. We lose that sensitivity later in life. And so there may be a better response in sleep repair in younger people than in older people. Okay, just a general trend there in the literature. Mannitol is used to reduce generalized edema in the body. It does have a place with this, and nerve blocks. Sensory nerve blocks in particular are important. Now for your management, I've given you medication protocols. They're in the handout. But I want to draw your attention to non-steroidal anti-inflammatories, and I've given you a list of many of them here, but the ones I want you to pay attention to are these top three. Ibuprofen, piroxicam, and diclofenic acid cross the blood-brain barrier as efficiently as diazepam, okay? And so these are felt to be better medications for centrally maintained pain. So these should be on your anti-inflammatory protocol, and anti-inflammation is a big part of this process. If you want a COX-2 inhibitor, then Celebrex may be your choice. Celebrex has a higher risk of cardiac disease, stroke, and renal failure, but in the lower dose, the 100 milligram tablet BID, obviously you've got more safety in that. Steroids are also a big part of your protocol, especially in acute situations. Beyond 6 months, studies show that steroids are not effective. If you're early in the process, hitting them with a Medrol dose pack before you start the non-steroidal anti-inflammatory may be the best treatment you can do from an anti-inflammatory standpoint. And then muscle relaxers, there are many. And there are many pros and cons of all of these things. I still prefer anxiolytics that are going to be mixed with nerve stabilizing drugs. And so the anxiolytics are working centrally. They're also working to modulate the transmission of the electrical signal up the spine, okay? So they're going to work centrally and peripherally as well. My preference is really Klonopin. It's the least addictive, okay? And then for control of bruxism, we could probably have a very lengthy debate about this. I use one drug, Desiril. I used to use tricyclic antidepressants. But I find Desiril has less hangover effect. If you're seeing some sleep interference with it, hungover the next day, you give it earlier the night before. And really 25 to 75 milligrams probably ends up being the practical range for most of the patients. And then to stabilize nerve conduction. So once you transduce from the nociceptive fibers into the channels, and then from there modulate up and upregulate the neurontin and the Lyrica are going to be beneficial. It's easier to titrate Lyrica, so the pregabalin, my experience is you do not have to go to high levels. The manufacturer will get up to 300 milligrams per day. I've had patients respond to as little as 25 milligrams once a day or twice a day. If they're going to have a dental procedure, I have them take 25 milligrams before the procedure. Okay, so you're stabilizing the nerve before they're traumatized with a dental procedure. And then non-narcotics, Tylenol is a very good drug. And you can give up to 4 grams of Tylenol a day for pain control. Another thing that's been found to be helpful is naltrexone, which is actually an opioid antagonist, but naltrexone, especially nasal spray, can help to keep some of the pain patterning down. And then the key NMDA receptor blocker that's going to get to glutamate is ketamine. Okay, ketamine is getting a lot of attention anymore. Attention deficit disorder, chronic pain disorders, CRPS type 1. You'll find pain anesthesiologists in particular who run ketamine clinics to apply that type of therapy. And ketamine, to me, is the indicated treatment for higher level problems. There is something new that has come out of Italy. It was published in the Journal of Rheumatology. They actually found that a bisphosphonate, neurodronic acid, reduced CRPS type pain. The initial part of the studies that I've seen here from the NIH are not as optimistic as this paper, but this may be something in the future for treating this particular condition. So in dentistry, you want to look for nebulous occlusion, okay, the dystonia. That's a sympathetic induced dystonia. And the problem with dental treatment in active CRPS is you've got a chance of exacerbating the problem. Occlusal treatment may actually make everything worse. And then this may spread to the extremities. There's typically very poor support in the community and high litigation potential from these patients. The occlusal complications is patients feel the bite is unstable. Doctors can't find a verifiable centric. Long centric oftentimes becomes longer because of the protrusion. Attention is redirected from the primary procedure to pain management. Patients think, well, all they did was a crown. Okay, and they had to mess up something about the crown. That's why I hurt. Can't you just get somebody to change the crown? No, not now. Now you have neuropathic pain, and it's not a matter of being able to go backwards. You won't get there. You now have something new you're going to treat. There are surgical risks for implant failure, periodontal healing, extractions of dry socket, and patients very oftentimes will get discouraged and go to somebody else's practice, which may not be a bad thing, okay? This patient had a very specific facial muscle syndrome. She had metal deficiency syndrome of the face, and I don't tell many jokes, so you better laugh when I do. So you can see she had all of these procedures. Now these were very poorly tolerated because you're vasoconstricted. Your healing capacity is diminished, and there's less bone density. Because of the vasoconstriction, there is actually less delivery of antibiotics to the area. That's why infection risk actually goes up. And so these patients are particularly problematic. There seems to be a trend in surgery right now, instead of doing joint preservation surgery, to do joint ablation surgery with total joint replacements. In a CRPS patient, they are a disaster because foreign bodies exacerbate CRPS type 1, and that's a lot of what was going on with this patient. A couple of examples. Here's a guy, chief complaint. Basically was that he had a dental procedure and his bite was never right. He visited his dentist 300 plus times, dating back to 2001. He was referred to an oral facial pain clinic. They didn't even come close to the diagnosis. They did nothing for him. He had CRPS type 1. I emphasized trauma history. The threshold event was the restorative dentistry, but this guy played football. He had multiple football traumas. He had a car accident. He had a wrist fracture. And he had lower back surgery. Lower back surgery will go up the chain, and it'll oftentimes exacerbate pain in the face. Okay, significant perseveration of his mandible with movement. And here's his bite. Not that bad. TMJs, very minimal damage to the disc. Here's another one. This guy had a restorative dental procedure 30 years before he came to see me. At that point, he had seen 50 doctors, reading like a who's who all over the country. He actually admitted to going out in the garage and getting the Dremel out and self-adjusting his occlusion. He had persistent perseveration of his mandible. He didn't do too badly with the adjustments, and thank goodness his TMJs were not that bad. It wasn't his primary focus. Another patient. This patient was treated with a Mago appliance, along with orthodontic movement to just change a small diastema space, okay? It was during the ortho, that was the threshold event, and she blamed the orthodontist for her crips, okay? Pain was exacerbated by even touching with massage, okay? Generalized muscle pain, class 2 bilaterally, molar prematurity. Basically what happened to her is her crips spread throughout her body, okay? And you have to create a long centric. She went for restorative treatment, and part of the problem with restorative treatment is if you treat her to MIP, she's off the back edge of the disc. Okay, actually this is MIP. And then fully seated, she's off the disc more. So restoring this bite, you're still gonna have the musculoskeletal problem at the temporomandibular joint, and she, like many of these patients, would therefore get into a wind-up phenomenon. We have a specific protocol for surgery patients. We do a stellate block, we do ketamine, 1 to 1.5 milligrams per kilogram during the surgery. We do a pre-incisional auriculotemporal nerve block, and we repeat those nerve blocks at the end of the surgery. They are put on heat and not ice, and you don't over-mobilize them. Okay, we maintain pain control, and we repeat nerve blocks as needed. The other key in these patients is fat grafts. Okay, fat grafts are overwhelmingly helpful. Here's the end point of CRPS. It's heterotopic bone formation. This is the right TMJ right here. You don't see a joint. Totally obliterated by heterotopic bone. Severe crips patient. She is cleaned up. We do this under stealth assistance. So we actually put fiducials on the face so we can orient the patient's skeleton to a computer CT scan, and then we can go in and we've got more control over the instrumentation and knowing where we're working. We have to build an antenna to transmit the patient data back to the computer, but basically this is where we start out, solid bone, and you begin removing bone with the instrumentation until you get back to what looks like the TMJ. And here's condyle distracted, here's condyle seated. There's now space there. This is filled with fat. Okay, that's the removed product. And you can see on the post-op CT how the joint has been recreated. Joint preservation surgery. That's what CRPS type patients need. Okay? And then additional pearls, watch for ice. Okay, it's not your friend, it's your enemy. Watch what happens with sleep. Bushman readily acknowledged that sleep apnea is a risk factor in CRPS type 1 patients. And now back to our example. Does she now begin to make more sense? We don't have to have 20 diagnoses. We have one diagnosis to explain pain, dystonia of muscle. Dystonia of muscle was mandibular movement, incisal prematurity, and dysphagia. We have vasoconstriction. That's creating the scotomata in the retina. Okay, so it's changing her vision. It explains the burning pain. It explains her altered movement of her mandible, and this patient can be basically diagnosed with one diagnosis. So I'm going to leave you with this. This is a form that I've developed in the office. You have my permission to use it any way you want to. All I did was take Budapest criteria. I made a form out of it so that we've got ways of checking symptoms and signs when patients come in. Page number 2 is a summary. How did they do to nerve blocks? You're welcome to use this, okay? And it's also giving a checklist of other things I want to look for in these patients to rule out to come up with a diagnosis of CRPS type 1. So, concluding thoughts. Hyperesthesia and allodynia. Are we making the correct diagnosis when we say this is a TMD patient? Is that correct? Okay. Is positive cold stimulation of the teeth after trauma really pathognomonic for RSD CRPS? Vasomotor. Are we overlooking color changes and asymmetry? Pseudomotor. Are we making a correct diagnosis of pulpitis? and edema in the pulp. And motor. When you see a patient with dystrophic movement of the mandible, you have to ask yourself, what is the source? What is the system? Is it in the trigeminal system? Is it in the cervical system? Is it in the sympathetic system? And with the differential nerve blocking, I think you can get a little bit closer to what the truth is. So, my goal was to try to endotype CRPS type 1 as a subset of pain patterning that is encountered in what we call TMJ-TMD patients. And my further goals basically were that I wanted to teach you the value of implementing a greater auricular nerve block. I wanted to show you how you can begin to integrate the sympathetic nervous system into dental management and dental treatment. I also wanted to begin the process of unifying perspectives on facial pain and sleep. And I obviously am going to come from a perspective where I'm going to be emphasizing the injury to the temporomandibular joint and how that plays a role in chronic oral facial pain patients. I want to expand your envelope of treatment so that you can improve the care of patients. And I want to thank you all for being my friend. Okay?
Dr. Piper for an extremely informative lecture. Everyone in here has been listening extremely intensely. Thank you very much, Dr. Piper.